and welcome to our webinar. My name is Lucy Silk and I'm a dental tutor for Health Education England. Our aim this evening is to answer some of the questions that we all share as we prepare to return to practice, as it seems that the new normal is anything but normal. And our guests this evening will be helping us make sense of the national guidance from the Office of the Chief Dental Officer and Public Health England. Before introducing you to our panel, some brief housekeeping. This webinar is being recorded and will be available as a link from Health Education England and LDC websites. We've muted and turned off all incoming video from everybody watching. However, you can ask questions using the Q&A function at the bottom of your screen. Whilst we probably won't be able to get through all of these questions, we will collate them all for the panel and aim to share answers with you in the coming days. This webinar won't be addressing any NHS contractual or financial arrangements. Somerset LDC have been instrumental in organising this event at very short notice, and I would like to thank Jeff Worrell and Andre Lowe particularly. So, our panel this evening are Jeff Worrell, Chair of Somerset LDC, Andre Lowe, Secretary of Somerset LDC, Alistair Morton, Consultant in Oral Surgery, Chris Bell, Honorary Senior Lecturer, Matt Jerreat, Consultant in Restorative Dentistry. Thank you all for joining us this evening, and I'll pass you over to Jeff, who would like to say a few words about the LDC.
Thank you, Lucy, and welcome from Somerset LDC. We're very pleased to be able to support this, our first ever webinar, so fingers crossed, no hiccups. It's been suggested that I explain to a lot of our new listeners or watchers what the LDCs actually are. They're a statutory body set up at the start of the NHS in 1948. Currently, they represent NHS dentists who are on the NHS performers list in their areas. There are 7 LDCs in the southwest, from Gloucester right down to the tip of Cornwall, including the Isles of Scilly, and Dorset have come on board the Southwest group fairly recently. In many, their elected members, though, have changed their constitutions to include dentists from all the spheres of dentistry. During these strange times, I think it is true to say that your LDC, no matter where they are, represents all dentists in their support of NHS England Southwest Area Team. We've all been directly involved in regular meetings with the area team and have been able to bring your queries and concerns to their attention, as well as sharing as much information as we can with all of you. Sometimes, all we've been able to report is that there is a lot of work going on behind the scenes. Today, we are very fortunate to have with us 3 of those people who've carried out a lot of that work. And so, without further ado, I'd like to hand over to the first of those, Chris Bell.
Thank you very much, Jeff. I'm just about to share my screen. So one of the main things that's driven concern during this period of pandemic has been aerosols and droplet spread. And so looking at the main terminology, SARS-CoV-2, which is the basic virus, is spread, as we know, by contact. And these are the last 4 are terms which have become to be used within dentistry: splash, splatter, droplet, and aerosol. Now, moving forwards, because this will feed into what a couple of our other presenters are saying today, it's about the fluid particle size. So splash, splatter, and droplet are all larger than 5 microns, and they don't remain suspended, and they're airborne only briefly, whereas aerosols are less than 5 microns, and they remain suspended in air depending upon the local environment. So if you're looking for non-aerosol generating procedures known as non-AGPs, protection is usually required for direct contact and also for splash, splatter, and droplet. And if we move into aerosol generating procedures known as AGPs, the protection is required for suspended aerosols which may come into contact with mucous membranes. My colleague Alistair Morton has been leading this area, and I'm just going to hand over to Alistair.
Okay, thanks for that, Chris. Hopefully presentations come up now. So what I'd like to spend a little bit of time talking to you all is just some of the work that we've been doing as a group, trying to get to the bottom of PPE, the type of PPE we should be using, and just sort of sharing that with you. So obviously, the first thing is sort of a bit of a disclaimer, really, in that the evidence that I'm going to present today is not really opinion. It's not really local policy, it's national policy. So this is guidance that's come out of NHS England, Public Health England, and the Health and Safety Executive. Now, like everything in science, it's constantly changing, and COVID is no different to that. The situation is constantly evolving, and it's likely that dentistry will continue to evolve, both as new evidence comes out to support the guidance, but also it's likely the guidance will change on the basis of how much COVID there is around, and some of the dentistry that obviously none of us could do may actually change as there's possibly more outbreaks in the future. And obviously it's interesting to note that over the last 48 hours, southwest of England has become one of the highest regions with the highest R factor in terms of risk of infection. So this is sort of a bit of a messy slide, and it's kind of like a bit of a roadmap to recovery. So these are sort of multiple aspects of you guys getting ready to open your doors. There's sort of patient-related factors, there's dentistry-related factors, there's all sort of social distancing, the vulnerability of both the patients and also your staff. The practice that you're going to be reopening will look very different both to you and to your patients than the practice that you left when it shut. And that's going to take some more in terms of the environment. One of the big issues is going to be PPE, the availability of it, and also the fit testing. Before we actually get to the place where you're ready to open doors. And it's quite reassuring to know, both in secondary care and primary care, that there isn't that big push just to open just because you need to open. Actually, it's more important that you get all your policies and procedures in place, and you get yourself to the point where your staff are ready, your systems are ready, and you've got your PPE in order for you to be able to open your doors to the public. So some of the areas that I'm going to very briefly cover this afternoon are sort of the hot topic of AGP versus non-AGP, and with that the sort of the different levels of PPE that are required to go along with that. So I'm going to talk sort of slightly artificially about standard and enhanced PPE. I'm going to talk a little bit more detail about the FFP3 masks and respirators, and kind of linking that in with what to use where and when. And I'll touch briefly on sort of sessional use and really, really small amounts on gowns, which is more for aerosol generating procedures. So in dentistry, nothing in life is really clear cut. There is no black and white. So there's this artificial divide that's been created between non-aerosol generating procedures and aerosol generating procedures. Now, some of those are reasonably simple, things like examination, radiographs, use of hand instruments, extractions, simple extractions. And then you've got, obviously, at the far end of the opposite extreme, the aerosol generating procedures would obviously include things like high-speed drills, ultrasonics. And then you've got things like prolonged surgical extractions. What is a surgical drill? Where does that sit in there? Does it sit in the AGP, the non-AGP? And for a lot of this grey area, the science is not really there yet. I've no doubt that it's on its way, and it will sort of help directors as a profession as to the best way forward and how to make dentistry both financially viable, but also sort of to broaden the availability to patients. And there's things like, a high-speed drill, which is clearly an AGP in its own right, but is it an AGP with high-volume suction? Now, those are things that will come. Critical to all of it is your clinical triage, and I think really this is one of the most important aspects of it. You really need to try and work out, if we're going to have these divides, and there are reasons for having to divide stuff, but it's all inherent with that is your treatment planning, both from the restorative surgical perspective, but also from the patient, the vulnerabilities of the patient. And this sort of general risk assessment is absolutely critical to that. So obviously the basic standard PPE is sort of all old friends to ours, really. It's the fluid resistant surgical mask that standard sort of practice would have been before. Many surgeries are full of this stuff. And historically, we might have not used eye protection, or if we're wearing glasses, that might have been all that we'd have used, or we'd use a standard mask or mask with a visor that's included with it. Now, one of the additions that's come with that is the use of aprons that's been recommended by PHE as part of this sort of standard PPE. As a group and nationally, it's recommended that you use a visor rather than an integral visor. So you have a visor that goes over the face of your fluid-resistant surgical mask as well. It's an extra layer of protection both from droplet and splatter. So that's the PPE that we all know and love. What's coming with COVID, unfortunately, is the enhanced PPE that's become a requirement, and that's because of the need for increased respiratory protection. This is particularly from aerosols now. So now we're talking sort of more sort of aerosol generating procedures. And there is some dispute in terms of international who recommends an FFP2 mask, but the UK PHE is very clear. It recommends FFP3 masks or respirators for aerosol generating procedures. There's a clear guidance about the use of eye protection, and there's a recommendation of the visor, which again gives good protection for the face of your respirator, protecting it from splatter. And you've gone obviously for the gloves. One of the other good things about the visor is it also gives you protection if your mask is valved. If you've got a FFP3 mask which is valved versus non-valved. Now there's been some debate as to whether that puts patients at risk by having a valve respirator. And again, the PHE guidance is that by using a visor over the top of that, you're preventing splatter and droplet from the practicing nurse or dentist towards the patient. The alternative is to put another mask over the top of your valved FFP3 mask, but actually that's not very comfortable and not very practical. The reason why we mostly use valved respirators or masks is because actually it's quite tiring and you feel constantly slightly short of breath with an unvalved one, but that's the reason for it. Now, essential in all of this is that actually the FFP3 mask needs to be fit tested to your face. There are many different types. Some will fit a certain shape of face, size of face, others will not. And it's not just a matter of fit testing. You actually need to make sure that the person who's putting the mask on understands all the aspects of wearing the mask and care of the mask. There are lots of different alternatives. One of the questions that's been faced across the region is lack of PPE availability, and that's a national problem. Now, that's not a political problem, it's just a straightforward fact that everybody wants to have these masks, and that's everybody in this country, everybody in this region, and everyone across the world. So there are stock issues. One of the things that we've been trying to source as a steering group is sort of a more sustainable solution. This is not advertising any particular company. There's a number of these type of respirators out there which are reusable. The advantage of some of them over others is that some of the first ones we looked at could be autoclaved, but there's sort of limited number of cycles. Something like this JSP mask is very nice because the filters are integral, they can be disinfected. The mask itself can be wiped out and disinfected. It does have a valve on it, but as we've spoken before, you can either put a fluid-resistant surgical mask over that, or you can you would have a face shield anyway to protect your face and the FFP3 mask from splatter. There are a number of different types of these, and really with all of the types of masks that are available, there will be no one size that fits all. So these types of masks come in 3 sizes. They do full face ones. And it's interesting because when we first started wearing these, some 10 weeks ago, when we started wearing FFP3 masks, we thought that actually patients would be quite scared by these kind of respirators. But I suspect now that if you didn't wear a mask of some shape or form, then I think most of your patients would be calling you out and wondering why. So the alternatives to these, and these all need to be fit tested, the alternatives to these are powered respirators. So these draw air in through oh, sorry, not gone too far. So these draw air through the filters and then pump it out. So the air comes out through the sides of the mask, vented through here. So the advantage of this is it's much easier to talk to patients. They can see your face, so you have all that sort of, you know, non-verbal communication thing that's going on. And there's multiple different types of them on the market. They are much more expensive, but all of these kind of masks, they're more sustainable. The filters will last up to 28 days. And when you're looking at them, you just need to get from somewhere that's reputable. And you just need to keep an eye on the stocks that you've got, because there are issues in terms of sort of reordering, because there's quite widespread use of these masks now. If everybody buys their mask today, then everybody will want the replacement filters in 28 days. And that can be an issue. 3M's do an amazing mask that's very similar, but then suddenly nobody could buy the replacement filters. So you just need to go into this stuff with your eyes open. There's fairly clear guidance that's coming nationally from PHE and NHS England as to what should be used where. Initially, that pretty much all the guidance was based on hospitals, and that wasn't easily transferable, but there was some nice guidance for dentistry and splitting it up into sort of the type of PP you'd need to use for different areas in this non-aerosol, aerosol generating elements to it. So this is clear, this is open to the public, and it's probably been widely seen, but essentially you're looking at different levels of PPE depending on your activity and therefore your likely exposure and risk. So as an algorithm in the urgent care centres, this is what we've been working on. We have a basic PPE which is in keeping with PHE guidance, which provides protection for the whole team. So you need to think about protection for everybody, be that security staff, be that your receptionist. And we have the fluid-resistant surgical mask, the full face visor, the apron, the gloves, and that is our standard PPE for non-aerosol generating procedures. That's for both the dentist and the nurse. And we also use it for the runner who's outside of the room when an aerosol generating procedure is being carried out. Now that's very different from the type of PPE that would be required for an aerosol generating procedure. And for those you'd need a fluid resistant gown and an FFP3 mask. Now, one of the things that's really important here is that triaging and treatment planning and actually having both your initial proposed treatment and what potential backup treatment might be required, because we all know that sometimes you take a tooth out, it doesn't always go to plan, so you need to have plan A and plan B. And it's really important that you have a very flat hierarchy in your team. And the team, both the dentist and the nurse, should be able to share the levels of concern. We put this in right at the beginning and said that actually the level of PPE needs to be appropriate for both the patient and the procedure. And although it's really important you don't just default to using an FFP3 mask for everything, and there's a number of reasons why I say that, it is something that there is no sort of straight artificial divide between non-aerosol and aerosol generating. So you might find for something that you think probably will be non-aerosol that stands a chance of becoming an aerosol generating procedure, then you might choose from the start to be using enhanced PPE rather than having to change halfway through. And there should always be an opportunity for discussion. None of these things are set in stone. So one of the other things that's come with this is the concept of sessional use. Now, obviously, FFP3 masks, they're not easy to get hold of. Some of you guys have probably already worked that one out. And they're not cheap either. And if you're using them for a single patient, you will get through quite a lot of them. And very rapidly, you'll run out of stock. So one of the things that was sort of touted quite early on was the use of PPE, enhanced PPE on a sessional basis. Now, the concept for that works really well in a ward or an ITU setting. There is a limit to how long you can actually physically wear it because they are quite uncomfortable and unpleasant. But obviously, what you don't want to be doing is taking your mask off and on and reapplying it, because then there's a risk of contamination. Now, what you can do and what is suggested is if you are going to use your FFP3 mask for a session, and that could be anything between 2 hours to 4 to 6 hours, I think realistically 4 hours is kind of a maximum, you want to have some splatter protection over the top of your mask. So when you take your gown, your gloves, your apron or whatever is off, they're all single use, then you want to be able to take your visor off, but leave your FFP3 mask in situ while you're using it on a sectional basis. The gowns really only needed for aerosol generating procedures. The recommendation is that they are fluid resistant. There has been some further guidance that's come out from PHE considerations when there have been shortages of fluid resistant gowns, and those can be non-fluid resistant, or they could be old-fashioned laboratory coats that we used many years ago. But it needs to be recognised that those need to be either disposed of, or they need to be washed in the same way that your tunic and everything was. And there's some beautiful guidance that came out of the BDA on that. FFP2 masks have been recommended as an alternative to FFP3 masks, but only in considerations of acute shortages. It's not a recommended default position. So again, very briefly, I would say that one of the key critical things about PPE in terms of times of COVID is that actually more than ever, and I think dentistry is quite good at this, but more than ever, it's about team working. And I think it's all about information. It's about your team brief at the start of the day so that everybody knows what role they're playing, whether they're anticipating a day of aerosol generating, a day of non-aerosol generating, whether it's a mixture, who's doing what role, what PPE is going to be required. And also on a case-by-case basis, what sort of the unexpected events that might come up. And sort of agreeing a PPE level of PPE, whether it's going to be enhanced or whether it's going to be basic for the case that you're about to start. The other thing is, having been fit tested once in your PPE does not mean to say that you're putting on effectively each time. And each and every time you put especially your enhanced PPE on, it needs to be checked by your buddy. So you really need to work as a team. And obviously the critical thing of this is that your PPE is part of your process and your SOP for essentially making sure that your patient care and the care of your staff is as safe as it can be. And that's right back to the environment, the risk management for your staff, any risk factors they've got, any risk factors for your patients. And the PPE is a small but critical element in it. So at the moment, I'd like to just end there, and I'm going to hand you on to Matt, who's going to do the next bit. Thank you.
Thanks, Alistair. Just understand that some of you haven't been able to get on, and I think some of the questions or some of the chat has been, is this going to be videoed? It is being recorded, and I imagine that it will be shared amongst all the LDCs, so welcome. There's lots of guidance out there, and for those that are hot off the press, they'll probably realise that just published has been the FGDP and the College of General Dentistry setting guidance out on how you can safely get back to dentistry and the management. There's national guidance from NHS England, and there's specialty guidance from restorative dentistry, oral surgery, as alike, and also Health Education England, and in particular Yorkshire and Humber Health Education England website, if those haven't seen it, is a really good resource. There is a video that helps dentists get back into the practice to show how the patient will flow through and some of the tips. And we thought it would be a really good opportunity to actually show that video now if you haven't seen it. So apologies for those that have already, but I'm going to now share my screen and show the video.
Set up for urgent dental care within Yorkshire and Humber during the COVID-19 outbreak. It provides examples of good practice based upon current guidance. However, providers of urgent dental care need to keep up to date with guidance, in particular from Public Health England and NHS England. Prior to a patient arriving at your surgery, they should be called and further triaged regarding COVID-19 symptoms and the need for urgent dental care. Where patients are able to consent for themselves, they should attend on their own. Any exemptions need to be confirmed, and where payment is required, ideally this should be arranged over the phone. Patients should also be given relevant instructions with regards to their attendance, including waiting in the car on arrival. Once the patient has arrived, they should call the practice and remain in the car until the practice are ready for their attendance. At this point, the escorting dental nurse will don the appropriate PPE if they cannot maintain a safe 2-meter distance from the patient at all times. Following a phone call from the practice, the patient will attend on their own, ensuring that they do not bring any unnecessary items such as bags or coats. Your practice will need to make sure that there are single entry and exit points to allow for one-way flow of patients where possible. The escorting dental nurse should open the door, ensuring that the patient does not touch any surfaces where possible, and social distancing measures should be applied, including markings on the floor to indicate where the patient should stand, and also areas not to be touched or crossed. The patient should be given an alcohol hand rub to be used once they have walked into the practice. Thereafter, a non-contact thermometer should be used to assess the patient's temperature in cold sites. However, if this is not available, an alternative thermometer could be used, ensuring that they are cleaned appropriately. If the patient is unable to pay by card in advance, then any cash should be brought in a wipeable bag and cleaned once received. It is important to zone your practice so that patient travel is minimised. In order to prepare the surgery, all unnecessary items should be removed, and only the essential equipment and materials required for that specific treatment episode should be set out. A trolley should be set up outside the surgery should any additional equipment be required mid-treatment. Ideally, there needs to be a minimum of 2 active dental surgeries and separate donning and doffing stations. This 4-surgery practice has the 2 end surgeries set up for treatment and the 2 middle surgeries set up as separate donning and doffing stations. Where this is not possible, a clean surgery can be utilised for donning the PPE prior to the patient's arrival. If a doffing station is not available, then gloves and aprons or gowns can be removed within the surgery following completion of treatment, but eye protection and masks or respirators should be removed outside the surgery into a clinical waste bin. Once the surgery is prepared for treatment, the treating dentist and assisting nurse should be donning the appropriate PPE. Please refer to the Public Health England guidance and videos for donning. Once they're ready, the patient will be guided into the surgery, and then the door should remain closed where possible during treatment. Windows should be left open to allow for ventilation into the surgery. Where further equipment is required, the runner nurse can pass this through the surgery door, but should not enter the surgery at any point. After the patient is guided into the surgery, the escorting nurse can then clean any surfaces that may have been touched by the patient. Once treatment is complete, the escorting nurse can guide the patient out of the practice via the designated exit. The time of exit should be annotated and displayed on the door where possible. At this point, the dentist and assisting nurse can remove their PPE in the doffing station. Please refer to the Public Health England guidance and videos for doffing. In most dental surgeries, it will be safe to enter the surgery after 1 hour following the completion of treatment. The surgery should then be cleaned in the appropriate PPE using a chlorine-based disinfectant at the appropriate strength. Please see the Public Health England guidance on infection control and PPE.
Okay, so hopefully that's helpful, and I'm sure that link will be made available as well from the LDCs if they haven't already done that. There's also going to be more guidance coming out for us in the Southwest, and I know that we are keen to do another Q&A later in the week for those that are interested. But now I'm going to ask Lucy to see if we've got any up-to-date questions.
Thank you, Matt. Yeah, we have got a few questions coming in, quite a lot of questions coming in. So if I can start with, how long can I leave it between patients? Okay, well, I know that the video did mention that briefly, but it does vary. And following on from Chris and Alistair, you'll know that they were talking about non-AGP and AGPs. And so for non-AGP, I think the guidance is that we follow the HTM 0105 standard, which is a normal turnaround.
clean between patients. For AGP, this does depend on the environment. And so for those that have a theatre set up in their practice, which I imagine isn't many of us, the air transfer per hour can be up to 16 times. And that therefore means that the time between patients can be reduced, maybe down to 15 to 20 minutes. For those that have a window, and you noted that they said open the window, that air transfer per hour is going to be a lot less. So the recommended time is 1 hour for an AGP. If you haven't got a window and you haven't got any air circulation, then that's going to be a lot longer. And the guidance is that you actually maybe want to get an infection control team to come to your practice if that's possible, and look at the surgery setup, look at how it can the patient can flow through, and then they can give you further information specific to your own practice needs.
Thank you. So following on from that, another question: what are non-AGPs and AGPs? Can you give some clear examples?
Okay, so this is the hot topic, and for those that have already read the FGDP guidance, that will be impressive because it was a very good document. I think it's over 60 pages long, but they talk about it as aerosol generating exposures, and I think and this is where we can sometimes get confused between a non-AGP and AGP, and then these aerosol generating exposures. But I actually quite like the way they look at that, because they look at the risk between adding a risk to high to low. And they do actually have a couple of pages. I haven't read it, but I know that pages 29 and 30 talk about this aerosol exposure and put it into high and low risk. But that's one way of looking at it, and I think it's important. And on non-AGP, I feel is something that doesn't require a high-speed drill or a 3-in-1. And so looking at it from that way as well, there is again some guidance on it. So it's a combination of the two. And I think it's important to note that. So when you're doing some treatments, if we're starting to use a 3-in-1, then it will be an AGP prone procedure. But the risk may also be low, so that may then support. So it's using the combination of the two. And I think each dentist has to take on board that and use that when they're looking at each of their patients.
Thank you. So could you just clarify for us, because a lot of people have asked, is the slow handpiece AGP or non-AGP? Okay, so I personally would say it was a non-AGP. If you had a water with it, which we know some slow handpieces do, then I would say that was an AGP. I think if you're looking at the AGE that the FGDP guidance has talked about, you may then consider it as a low risk using a slow handpiece. And so that would be also another way of considering it. But personally, I would say a non-AGP. That is my opinion, though. Thank you. So a question for you, Chris. Chris, are you there? There are a lot of different FFP3 masks, and a question has come in: are they all the same quality?
Thank you very much, Lucy. Well, they all set out to provide the same performance, which is filtration of particles down to 0.3 of a micron. Now, different companies have different designs. Some are valved, some aren't, some have a more rigid shell, and some are soft. So to answer your question, no, they're not all the same. And because they have different manufacturers, the requirement is if you're fit tested for a particular mask, you can't transfer that fit testing to another mask. So if in your supply chain, which is what some of the urgent care hubs have experienced, you may be fit tested for a mask and then the supply chain changes and you have to buy another company's mask. If it's a different make, you have to be refit tested on that particular mask. Now, I know FFP2s have also been in discussion and different countries have been using FFP2s. The difference between them, and there's a good reference site on the Health and Safety Executive webpage which discusses this, is the filtration rate with an FFP2 mask is about 95%, where the filtration rate for an FFP3 mask is 99.5%. And there is conflicting guidance out there, and different professional societies will have comments. And again, as Matt has said, this is for you to take on board when you're doing your risk assessments.
Thank you. So another question, how do we get fit tested? And people have mentioned there are some videos on YouTube and online. Can we watch one of those videos and then fit test ourselves and our team?
Well, I'm going to pass this back to Alistair, because Alistair's got a huge amount of experience in this, gained in the last 10 weeks. Alistair, over to you.
Okay, so that's a really important and really good question. So I think, to be honest, my answer to that is no. I think that for a number of reasons. I think there's sort of two aspects to this, really. One is the whole concept of fit testing. Although when you watch the video looks incredibly simple, but that's only one part of it. So it's about the whole point of fit testing is about looking at your staff, working out their vulnerabilities of your staff, whether they've got any comorbidities that might make them at risk of wearing masks. It's about explaining and showing people how to effectively fit the mask, so that on a day-to-day basis, when the fit tester has left the room and gone back to their place of work, that actually the person who's wearing the mask actually is wearing it safely, because they won't be fit tested on each and every time they put the mask on. And also there's a health and safety aspect to it. So there's a legal requirement for the records to be kept. And I think the other concern I would have, although the fit testing kits are reasonably cheap to buy, it would be a question of sort of how often would you be how often would you be testing people? If you're a small practice that's just doing it maybe once in a blue moon, you're probably not the right person to be doing it. Now, I say that there are issues in terms of fit testing. There's going to be at least two big rate limiting steps to practices opening, and we've found that with the urgent care centres. Probably the biggest rate limiting steps that we came across was finding PPE for them and then getting them fit tested to be able to use it. So we have set up or made a start on setting up some provision across the region. So we now have about 30 people fit tested to do the testing throughout the southwest region, and we've got quite a number of kits that have gone out as well to go with it. And that fit testing is available through HEE, and it's also been rolled out to the LDC leads. So I think there is, as well as that, the availability through private practice and private companies who are there in the market that can provide that fit testing. It is a capacity. Not all of the slightly dodging the question now, but not all of the PP that is FFP3 standard needs to be fit tested. So if you're looking at some of the forced ventilation masks that are out there, the powered hoods, those do not need to be fit tested. They're also reusable. So actually they can be taken on, taken off. They don't need to be worn for a session, as do the sort of the more half-face respirators that 3M do, or JSP do, the Force 8. Those can be taken off in between patients and disinfected. But I think fit testing per se is critical, not just as a tick box, but actually to make sure that when you put a mask on at a later date, that it is actually effective for you. And I know that there's debate about FFP2 masks, and the recommendation is that those are fit tested as well. What HSE have said is that if they're not fit tested, they're kind of the equivalent to fluid resistant surgical mask in terms of protection, which is in the 80% of protection. So I think fit testing is really key, but I agree it is going to be a rate limiting step.
Thank you. So another question on the same theme, really. Please, can you clarify the difference between using a normal surgical mask with a face shield and an FFP3 mask?
Okay, so and obviously you've got the respiratory aspect or respiratory protection. They're not the same. So an FFP3 mask is around about 99.5. Some of the sort of more advanced, expensive ones are even higher than that. You are not getting any of the. So we're suggesting a visor over the front of those so that you've got some protection from droplet as well. So it's reducing the risk of contamination onto your face. Some of the normal fluid-resistant surgical masks, yes, you can wear a visor on those. That will give you splatter protection, but you will not have as effective respiratory protection. And the fluid-resistant surgical masks that have the visor integrated, obviously you're not protecting the mask from spatter, you're just protecting your eyes. So,
thank you. Another question. Should we be asking our patients to use iodine nasal spray and mouthwash? Matt, can you help us with that one?
Yeah, before I answer that, I've just been looking at the Q&A, which is always a dangerous thing. And I know that some people have asked about the 3-in-1. And yes, it's a 3-in-1, if you're using a combination of air and water, would be considered an aerosol generator procedure. I know that the FGDP guidance has talked a little bit, or has talked about the fact if it's used singly, then it wouldn't be. And I think one of the concerns that dentists have is that they're so used to actually using it as a combination that the risk is to try and then use it individually. But yes, I would agree with the comments. The other comment that came up was the surgical handpiece. Is that a low? And I would say if you're using a surgical handpiece without water, that would be kind of dangerous. And so the fact that you'd be using it with water would be then creating an aerosol generator procedure. And I hope that helps. I know that the other Q&As we're going to look at afterwards and try and provide further questions. So everybody that has answered a question, we will answer as well if we can. And if we can't, we'll certainly go to some of the sources that have produced the documents. Going back to the question about povidone iodine, the paper that I think people are referring to is the one that Shalicum and others have published. I think it was in May this year. And it talks about the fact that iodine is, or the povidone iodine is an antimicrobial, and it has an antimicrobial action in the upper airway. And so perhaps some people have used that to kind of kill off the bugs. Now, whilst I believe FGDP guidance has, as I say, I haven't absolutely categorically read it in full, so apologies for those that have put the hard work into it. I don't believe they recommend the use of or don't recommend that you need to use an oral mouthwash. And I do believe that the national guidance is that we don't need to. But for sure, if people want to, and they've looked at the evidence and they can get hold of it, and they want their patients to have that experience, because I understand it's not very nice, then clearly then that's something that an individual practice may want to do. But it's not what the national guidance is saying.
Thank you. So what happens if we start a procedure and we expect it to be non-AGP, and then something happens halfway through and it becomes an AGP procedure?
Who's that to? Alistair.
Alistair, can you help us out with that one?
I think it was you, Matt. Matt, it was you first.
Yeah, no. Okay, so I think, I think it's a tricky one, isn't it? Because that is the nature of dentistry, isn't it? Nothing always goes to plan. I think obviously the key aspects of this is the initial treatment planning as much as possible. I think it's about anticipation, and it's about having a fallback position, which is going to be slightly different for different specialties. So I think one of the things that's been really, really reassuring at this moment for dentistry, especially urgent care dentistry, is that most patients are actually quite understanding, and I don't think patients are expecting to revert straight back to the type of dentistry that they had before. I think are really some really clear explanations with the dentist, with the patients in advance. So one of the things that's been talked about, say, in oral surgery, is that expectation or that discussion with the patient. So you've got consent in advance that their treatment might go as far as possible on that day, and then might either need to be suspended, or there may need to be a changeover in terms of the type of protection that's been required. For something like restorative, that might be more straightforward to sort of read on or sort of move into sort of an aerosol generated procedure. For oral surgery, there's always that fallback of if a root breaks off that can't be retrieved. It's not unusual in dentistry. Either refer to an urgent care hub or to secondary care. Those avenues are still available. I think the key really is a conversation with the patient. Now, it might be that if you've got a case that you think is borderline non-AGP, AGP, then it would be reasonable and sensible to be pragmatic and plan for an AGP. The downside of that is that, or the upside of that is that if it doesn't turn into an AGP, then you have no turnaround time, so you don't need to wait for the surgery to rest. You can just see the next patient. Obviously, the downside is that if you've not planned that, you then not need to have some rest time for your surgery, and that has obviously consequences for your ongoing planned next patient. I think if you've got reusable PPE that can be taken off, disinfected, and put back on, then that's less of an issue in terms of PPE resources than it is if everything is single use. But I'm afraid there will be times when you will start off down the road of a non-AGP, and unexpectedly you will come across an event which turns it into an aerosol generating procedure, or you need to abandon and replan for a different day or in a different situation. Matt, I don't know whether you've got anything you want to add there.
Yeah, no, I mean, again, I'm looking at the Q&As as well. And I think the FGDP guidance talks about mitigating risk and using rubber dam and high volume aspiration as well. And I think those are all things that we should be actively doing. And I agree, it's assessing the patient, the treatment plan, looking at what you're going to do, and understand that actually if you are thinking it's going to be an aerosol generator, preparing for it, but also using the things that we have so good at to try and prevent then any risk to the staff, and those things are rubber dam and the high volume suction, which we can all do as dentists.
Thank you. So Matt, a question has just come in. The use of rubber dam for restorative procedures is increasingly recommended. Does that turn a procedure into a non-AGP procedure by virtue that you're using a rubber dam?
I would say no. It would if you look at the FGDP guidance, which I think is actually quite helpful, it talks about that the risk will then be lower, but it will still be an aerosol generating procedure, but then the risk is lower. Does that mean that you still need to use the FFP3? Then I think you probably do. But again, we just don't, until we've got more information and knowledge, I kind of feel that that's where we should be. And that's the stance I would take.
Matt, I was just coming in on some of the questions. So the slow handpieces, which we particularly use in oral surgery, which rotate at a maximum of 40,000 RPM with external irrigation, I think at this stage we still have to regard those as aerosol generating, which might help some of the people who've asked questions earlier this evening. Yeah,
and I think some people have asked about placing dental implants, and I know that some people place dental implants very slowly, and that's a recommendation. Again, I think it's a big subject, and I'm not certainly going to put my name on that one, but I would consider, I would say it was an aerosol generator procedure if you're using water with any handpiece.
Thank you. Is an extraction an aerosol generating procedure?
I don't think I'll answer this because I've got two oral surgeons here.
Okay.
If I pick that one up for you, Lucy.
Thank you.
An extraction, a routine extraction, which you can achieve with dental forceps under local anaesthetic, would be classified as a non-aerosol generating procedure. It's if things deteriorate a bit, which nobody can plan for, and you're forced into considering to use a kind of oral surgery type drill, micromotor based drill, maximum speed of 40,000 RPM with external irrigation. As Matt and I have mentioned before, you're probably looking at an aerosol generating procedure for that. Again, coming back to what Alistair has said, it's preparation of the patient and consent. So these are unusual times in the pandemic. And I think if you prepare your patient for the fact that you may have a couple of issues with an extraction and a piece of root may be retained, you make best efforts to remove it with a non-AGP procedure, such as using elevators, but a small portion of the root remains. If that's been explained as a potential risk to your patient, and that's in the consent process beforehand, I think that's quite reasonable. And that's also being supported by the defence societies at this particular time. And that takes a lot of worry off clinicians when you feel you should completely finish the entire extraction, remove all root remnants. It may not be feasible this time. Coming to support what Alistair said, consent is a big issue here.
Thank you. So can we still refer to our colleagues in secondary care?
At this moment for oral surgery, the hubs are working extremely well. And they also liaise extremely well with secondary care. So it's probably preferable that you contact a hub for advice at this particular stage, because they can also contact secondary care on your behalf. And I think at this particular issue, because they have good PPE support, I do know the secondary care services have been very, very active at this particular point. So my personal choice, and I don't know what Matt and Alistair think, is consider your local hub first for advice at that point and take it from there.
And I would say that if that was for oral surgery, I mean, I'll leave Alice. Dallas, do you want to come in on that?
I was just going to say the only exception to that will be the urgence and the 2-week waits that should still be coming in straight direct.
Absolutely,
through the rapid referral route,
and that hasn't actually changed. So 2-week wait referrals have been the same throughout the last 10 weeks. For restorative dentistry, we are still seeing patients, not seeing patients, but taking referrals, and the first port of call will be telephoning those. But actually, if you still need support, there is that available. And we are still at the moment taking questions, and there's a group of consultants that meet twice a week if there are questions that meet online, and that includes oral surgery, restorative and special care dentistry. So we would actively ask you to carry on doing that if necessary, but refer patients in. We are open for business, and the good news is you have a new consultant in Plymouth, which for those that don't know, has just started, and I believe a new consultant in Gloucestershire as well at some point. So we are getting the support that dentists need, hopefully.
Thank you. One for you, Alistair. I think which PPE is required for decontamination people to wear in the decon room?
Okay, lovely. Okay, so I think just to reinforce the things we spoke about before, first is whether it's a non-aerosol generating procedure that's happened or an aerosol generating procedure. If it's non-aerosol generating procedure, then the decontamination will start as soon as the procedure is finished. If the procedure has been an aerosol generating procedure, then there needs to be a rest time with no one in the room, with equipment left as it is. And that decontamination time or that resting time will vary depending on the setup of your practice. But it will be a recommendation currently is a minimum of 20 minutes if you've got rapid air changes in your room. More likely it's going to be an hour for most standard dental surgeries. So at that stage, the idea of that stage is that that's then transferred that room environment back to as if you'd done a non-aerosol generating procedure. In other words, you would need a normal visor, fluid-resistant surgical mask, an apron and gloves. However, what you would need, as per national guidance, is a more of a deep clean than you would with just a standard wipe down that you would for non-aerosol generating procedure. And there's guidance out there as to the equipment to use for that. But you would no longer need an FFP3 mask for that, because that's the idea of the resting time.
One of the things on the Q&A is talking about air conditioning, and I think that's quite important. And air conditioning will circulate the air. So if you have air conditioning on, you need to turn it off, which does make the whole AGP process that little bit more uncomfortable, because obviously we're now coming in. Well, if it was this week, it would be scorching, and the weather and the hot environment is going to make that slightly different. So opening the windows is crucial. But yes, if you've got air conditioning units, you need to turn those off. I think
I think you've hit the nail on the head there, in that basically aerosol generating procedures are a bit of a killer for dentistry at the moment.
Do you recommend an air purifier if you haven't got a window in your surgery?
I'll take that one, Lucy. One of the problems with us at the moment as a dental profession is that we're very, very vulnerable to financial exploitation at the particular moment. And during the last 10 weeks, all of us have been receiving queries about ultraviolet light, decontamination units, standalone HEPA filtration units. Be mindful of what is being offered. the guidance which both Alistair and Matt have talked about mean that if you've got a still room with no air conditioning, that things will settle within a defined time and you can clean the room. It's mixed messages with these, and really before buying and moving to these things, it's worthwhile taking professional advice, because we are a vulnerable profession at the moment, and there are a lot of people wanting to sell us items out there which really probably may not justify your financial investment.
It goes back to individual dentists looking at infection control teams and having that advice from the professionals that can come to the surgery, look at your setup, and they will give you that professional advice, which I think is really important. And and I think if that is available, which I'm sure it will be, it's definitely to tap into it.
I think we've got time for just one more question. So I think this one possibly for you, Alistair. Assuming in treating all patients as potential asymptomatic COVID carriers could be extremely stressful for dentists and their staff. And the question is, how can these huge levels of stress and anxiety be mitigated?
Okay, I mean, I think that's quite a big ask to answer that. Thank you for that. I mean, I think dentistry is a stressful profession anyway in its own right, and I think that there's a number of things that we need to look into this. The first is looking at ourselves, looking at our teams, looking at our nurses, looking at our dentists, working out what our vulnerabilities are. We are not all the same. Some of us will have more risk factors than others. Obviously, we have a desire to get back to work and treat patients, but that needs to be balanced by our own risks. So I think there was a question that came in about a 70-year-old lady who's a nurse, a dental nurse. Now, some of our staff in hospital are on the front line. Some of our staff have been taken off the front line because of their vulnerabilities. And that's a risk assessment that has to be done by the practice managers, by the dentists, by the nurses, both as a practice, but also on an individual basis. And not everybody needs to do the same role. We work as a team. So some of the practices that we set up in the urgent care dental centres, some of the nurses were incredibly anxious when we first started, as were most of us practitioners in secondary care when they all started. And I think information is key. I think evidence-based information is key rather than opinion. I think it's about being open and able to share your concerns. And it's about being sensible about what is realistic and what isn't realistic. I think there's lots of things that we can do to mitigate the risk, both to us when we're out and about shopping and transport and all those kind of things. But there's also things that we can do at work to mitigate that risk as well to ourselves and our colleagues. And that's about the environment that we work in, whether we work in teams, making sure that we're protecting each other and using our PPE effectively. And it's also about just things like team brief in the beginning of the day, so that everyone knows what their roles are, everyone understands what their responsibilities are, and what their role in the team is. It's about having an open atmosphere that allows people to raise concerns and to have those concerns addressed. And it's also about debrief at the end of the day or at the end of the week, and things like there's support out there. There's quite a lot of support for both the NHS. There's Mind UK have brought out some guidance. BDA will have guidance on it. I think just talking and communication is the key, and recognizing that we all come at this from slightly different angles. We have slightly different concerns, and most of those concerns can be addressed. You can never remove all the risks in life. That's true. I have a motorbike, as does Chris. Life is about balancing risks, but we can mitigate a lot of the risks that we face in life. And I think openness and transparency and sharing and working as a team are really the key ones.
Thank you. And if I could add to that, if you look at the Health Education England website for the South West, we've got a lot of resources there that address mental health issues, stress and anxiety amongst the profession. I'm so sorry we've not been able to answer everybody's questions. We've had well over 100 questions come in, but we've promised that we will put all of your questions to the panel. they've very kindly said that they'll answer these. What sort of timescale are you looking at, guys, to get those questions answered for us?
Matt, I think you were talking about probably arranging another meeting later this week, and I'm wondering whether we could also answer some of the questions and put them up on a website through the LDC. What are your thoughts?
Yeah, I mean, we'll probably stay on after this and think about a timeline, but certainly, yeah, we'll try and communicate it out certainly sooner rather than later. Next couple of days, I think, is fair.
Brilliant. Thank you so much. I'm going to hand back now to Jeff Worrell from Somerset LDC.
Hi, well, thank you to Aging Rockers and the mod for that. Really appreciate it and your time. I felt quite sorry for you, really, because of course the chat was coming in on the side of the screen here, and I felt that a lot of the people putting comments and had read the FGDP guidance quite in detail, whereas I don't think any of us have had a chance to really look at that. So I think it'll all be tied up later in the week when we have another meeting, and really appreciate that. One of the queries came up there is about the urgent dental care hubs, how long they're likely to be going on for. And I think there is an expectation that they're going to be going on for quite some time, because reiterating what was said early on, there's no expectation for you to open your practice on Monday if you're not ready. You've got to carry on with the triaging, you've got to carry on with everything you've been doing so far, but if your surgery on your practice is not ready, there's no expectation, and hopefully the message will get out there to patients that is the case. Communicating and talking is vital, both amongst yourselves, your team. Find yourself a mentor. If you're really finding yourself stressed and anxious, then make sure you have someone to talk to. The LDC reps have put themselves forward to be at the end of the line if necessary. And I can also give a plug to a national in confidence phone line called Confidential, which is emotional support for dentists. I expect that to be pretty busy from now on. So just to reiterate, the recording of this will be on the LDC websites. We will share it with the other LDCs when it becomes available. And I think Lucy will confirm that it's going to be on the HEE website too.
That's right, absolutely. Yes.
Great. So nothing further more to say, but thank you to the panel very much indeed for your time, and all of the rest of you for attending. And if we can all give them a big virtual clap. Thanks. Have a good evening.
Okay. Thank you. Bye.